Good morning, everybody. I'd like to welcome you all to the meeting this morning. There are some things that I have to say before we start the meeting, and I'm going to try very hard not to cough. We're not expecting a fire alarm. If the alarm sounds, can all present leave the building as quickly as possible by way of the nearest exit. The designated assembly point is in the public square in front of Cast, beyond the fountain and away from the civic office. If there is anybody who needs help, then please wait in the refuge area at the top of the stairs where the emergency evacuation lift is located, and use the intercom situated at the left-hand side of the lift doors. That's the left. I'd be no good as an air hostess to call for assistance, and there won't be any roll call. Please put your mobile phones on silent. I've already done mine. This meeting will be audio-visually recorded and will be available to view on the Council's website and YouTube channel. Can I ask those present to use the microphones and remember to switch it off when you've stopped speaking? And that'll be the first thing I do wrong now I've told all of you what to do. All members of the public entering the Council chamber are accepting that their images will be retained and broadcast by the Council. If we have, I don't think we have any public or press in attendance, and they're intending to record or film any part of today's meeting, please ensure that this does not disturb the conduct of the meeting. And if you're visually recording, you are requested to only focus on that recording. So we're going to go to the agenda. So we'll start with apologies for absence, and we have actually got them from Sean Gibbons and Linda Curran currently. I don't think there's anybody else. No. Okay. So we're going to, we haven't got press or public here, so we have to say that we've considered the extent, if any, to which they're to be excluded from the meeting, and there would be no issues anyway. So are there any declarations of interest? So if we go to the minutes of the Health and Adult Social Care Overview and Scrutiny from our last meeting on the 8th of February and the 29th of November, so they're actually in our pack, can we agree these as a correct record? And is that seconded? Thank you. So, public statements. We haven't got any members of the public, and there are no items where public and press would be excluded. So we'll start and introduce ourselves first at this point.
Yes, good morning. Martin Greenhouse, Ward Councillor for Reticle in Wadworth Ward.
So my name's Glynis Smith. I'm the Chair of Health and Adult Social Care Scrutiny.
Caroline Martin, Senior Governance Officer, supporting this meeting today.
Councillor Bluff for Bessica Ward.
Councillor Sue Knowles, Armthorpe Ward.
I'm Councillor Ken Guest, and I represent Rosington, Bawtry and Ostfield Ward.
Councillor Yetunde, Whitley Hills Intake Ward. Thank you.
Right. So what we're going to do this morning are health inequalities and inclusion health in Doncaster. We've all had that report, and I'd like you guys now to introduce yourselves. Thank you.
Good morning, I'm Rachel Leslie. I'm Director of Public Health at City of Doncaster Council.
Morning, I'm Mario Staba. I'm community link worker with focus on Gypsy Roma and travellers at the ICB.
Good morning, everybody. I'm Mandy Espy. I'm the Health Inequalities Lead across Doncaster Place.
Morning, I'm Whitley Marie Smith. I'm a GRT Community Connector in Doncaster.
Morning, everybody. I'm Ailsa Layton. I'm the Deputy Place Director for the ICB in Doncaster.
Right, that's lovely. So can we start with the presentation, please?
We can. So to complement the report that we provided for you, we've got just a short slide set, and just before we go into it, just wanted to give some context to this item as well. So this is actually linked to two of the previous items that we've presented to Overview and Scrutiny over the last few months. So you remember that we had a look through the JSNA, and we also had the visit and the report around substance use services as well, visiting Sober Social. So they are linked. The JSNA Joint Strategic Needs Assessment gives us data, information, insight about our population, and some information about health inequalities as part of that. And then visiting substance misuse services and hearing about how they've changed is an example of one of the inclusion health groups as well. So today's report and the presentations and some questions that I expect you've got for us as well is a chance for us to highlight health inequalities, describe health inequalities in Doncaster, talk about inclusion health groups in Doncaster, and some of the focus projects and work that we've been doing to prove access and experience and outcomes from people from inclusion health groups. So we'll work through these, but what we wanted to do for Overview and Scrutiny was to give that example of how we need to apply that equity lens to all that we do to ensure that people in our inclusion health groups aren't left behind, making the case for being disproportionate and intentional about how we direct our resources to the more vulnerable people in Doncaster. And then how, when we ensure that we make decisions, so it's decisions about how services are funded and how services are delivered, that those decisions don't inadvertently increase any health inequalities gaps. So we'll work through these today. Again, just a 101 about what health inequalities are, and this is the national definition: avoidable and unfair differences in health between different groups of people. They're linked to the length of time that people will live in good health, so you'll hear data about healthy life expectancy and life expectancy. They are driven by poverty, and the cost of living crisis has impacted people further and brought more people into health inclusion groups and health inequality groups as well. That gap in life expectancy and health inequality gap is growing as well. We've seen life expectancy stall and decrease in or poorer health in some of our poorer communities. And then I hope through the examples that we'll give today, we'll demonstrate some of the difference that we can make when we really think about how services and functions are tailored to people in inclusion health groups, and that importance of treating people with understanding, compassion and kindness. I will bring Mandy and others in as well, but again, just to identify who we mean, who could be affected by inequalities. So the specific or protected characteristics that you'll hear, so differences between sex, gender, ethnicity, people with different disabilities, and Doncaster recognising people with care experience as well as possibly needing something additional when accessing services. Physical environments that we live in can provide division as well, the north-south divide, difference between accessing between urban and more rural populations, and the impact of air quality as well in some of our areas and places. Through the report, you'll have seen how we've described the socioeconomic factors, so the cause of the causes of good and poor health, so income, education, employment, and the support networks we've got around us, whether it's the friendships or our families, and also how safe people feel in their communities affects their ability to get out and about, be physically active, and to do the things that they want to do. Much of our focus today and in the report will be around health inclusion groups, which we often describe as people that are furthest away from services. You'll hear things like hard to reach, but I think what we like to describe is actually that services can be better tailored, so they're not harder to reach, but being configured or moving differently. So just an example of what some of those health inclusion groups will be. So people experiencing homelessness, Gypsy, Roma and Traveller communities, sex workers, people who are digitally excluded, and people affected by addiction, whether that's to alcohol or to drugs. And let's see. So I know that you'll have asked or be interested as well about life expectancy. So men with learning disabilities live shorter lives than people without learning disabilities. Similar for women as well, even more of a gap. People with severe mental illness live 15 to 20 years shorter, and that's all causes of mortality. So it could be at higher risk of things like suicide, or can be because of different coping mechanisms used often for people with severe mental illness. So more likely to smoke, more likely to, or less likely to be able to live a healthier life. Shockingly, the life expectancy for men who are homeless is just 47 years and 43 years for women. So when you've asked before about whose life expectancy is most affected, absolutely people who are rough sleeping. And then black women 3 to 4 times more likely to die in pregnancy and birth, and research studies around that have found numerous reasons around that, all of which are completely unacceptable. And then this here just illustrates where that real drop-off, where that real difference is for people experiencing homelessness and other severely excluded people. So when we said at the start about how we need to be disproportionate in the focusing of our resources, this is that both moral but also economic argument about why we should do that. Oh. So I'm going to hand over to Mandy for the Core 20 slides in just a minute, Mandy, but before that I just wanted to bring in the Health Foundation report. So a report published not that long ago, less than a year ago, that predicts what will happen around health inequalities in the future. So we're expecting that burden of ill health will grow, more people will be more unwell. That ill health will continue to be disproportionate, so people from health inequality groups, poorer communities, and health inclusion groups, that gap will widen. Ill health is the biggest driver of economic inactivity, so people who are not well either with mental health conditions or physical health conditions being unable to work and to do the other things that they want to do in their lives as well. And the call to action nationally as well, the NHS dealing with a large number of operational pressures that we must not move our focus away from health inequalities as well. And again, that need to be disproportionate and intentional about where we focus our resources. I'll bring Mandy in just now. So at the end of COVID, when health inequalities was again flagged through both COVID rates, vaccination rates in some of our black and minority ethnic populations and in some of our other groupings as well, we saw that there were people from different health inequalities and health inclusion groups that were affected worse by COVID. We said in Doncaster, do we have one person or an individual that works around health inequalities for us, or should it be part of everybody's job? And we got to the position where we agreed that it was both things, but we did probably need a single person that could work across place. So that is Mandy for us. I call her our health inequalities nomad. So she does work across Doncaster system and has been our kind of glue that's glued us all together across Team Doncaster around health inequalities, and the best person to talk to us about Core 20 plus 5. So there you go, Mandy.
Okay, so Core 20 plus 5 is an approach designed to support integrated care systems to drive targeted action in health inequalities improvement. So the Core 20 is the most deprived 20% of communities nationally, and for Doncaster that's 41.3% of the population, so a significant number of people within Doncaster, as you will all know, living in that level of deprivation. The plus groups are those that need more help than the Core 20. So often they're having poorer than average health outcomes, experience and outcomes, and they might not be captured within the Core 20. And for us, that will include people like those experiencing homelessness, sex workers, Gypsy, Roma, Traveller, prison leavers, etc. The 5 are 5 key clinical areas that actually, if we all focused on these 5 areas, we would see that we would improve health inequalities and we would improve outcomes for the population. So maternity is the first one. So coming back to Rachel mentioned that black women are 3 or 4 times more likely to die. The maternity pathway is around ensuring continuity of care for women from Black, Asian and minority ethnic communities, and also for women from the most deprived communities in Doncaster, well, not Doncaster, nationally. So it's both. It's not just saying that we're going to focus on one particular community. Severe mental illness, so ensuring those annual physical health checks, and this set off at a target of around 60%. I understand it's now about 75%. And Doncaster have a stretch target of 95% that Ardash are doing. Chronic respiratory disease, so this is making sure that people access their COVID, flu and pneumonia vaccinations, which sounds really easy, but actually it's quite difficult for many people to be able to access these services. So it's having that, again, health inequalities lens and focus on how do we engage and connect with people in a trusted way. Early cancer diagnosis, so that 75%, we know that if we catch cancer at stage 1 or 2, then people are much more likely to have a positive outcome. So there's a target of 75% of cases being diagnosed at stage 1 or 2 by 2028. And then there's hypertension case finding. So lots of people have got high blood pressure and they don't necessarily know that they've got high blood pressure. So going out looking for people who have high blood pressure or high lipid and making sure that people, or helping people to navigate the system to be able to access the treatment that they need. If we did nothing else but look at reducing smoking, we would have a positive impact on all 5 of those clinical pathways. So there's a huge amount of work going on around smoking cessation as well. And so that's, again, when we're looking to make every contact count, it's making sure that all of our partners are focused on supporting that. So just to give a bit of a sense of what's happening in Doncaster. So when we're thinking about the Core 20, what are we doing? So bringing partners together, and you can't underestimate how challenging that is, but how it's everybody's business. It's not one person's business. It's not one organisation's business. It's not just health. It's health, social care, it's voluntary sector, it's the communities themselves. So really bringing everybody collectively around the table to be cited and understanding where we're at. We're embedding Core 20 Plus into the Thrive locality health and wellbeing approach and the work that we're doing there within each of the localities. We're looking at high-intensity users of services who often will be experiencing health inequalities. We're supporting Core Plus 20 plus communities to access health and care, so understanding the barriers that people are facing when it comes to accessing care and looking at the different things that we can do. We've got the digital inclusion offer that Citizens Advice have been doing some brilliant work with primary care in bringing that advice out to GP practices. And we've got we're looking at the experience and outcomes of inclusion health groups who are attending ED, because I think that can be quite a challenge, both for the people attending ED, but also for the staff working within ED. So given that 43.1% of the population in Doncaster are living in that most deprived 20%, that it's not practical or realistic to think that we're going to do something for everybody straight away. So where do we focus? So at the moment, we're looking at the regenerative neighbourhoods. So Highfields, Hexthorpe, Stainforth, Bentley, Adlington and the city centre, and really looking at how can we, if collectively work together, this is the Thrive model, how do we collectively work together across health and social care and the voluntary sector with the communities to be looking at Core 20 plus 5 and looking at those different pathways. In terms of the plus groups, who have we got in Doncaster? So people experiencing homelessness, sex work, GRT communities, prison leavers, the deaf community, people with learning disabilities, veterans, ethnic minority communities and asylum seekers. So the list is quite long. And there is a lot of work going on with all of those different groups to improve their access to health. So we're focusing on language and translation, interpreter services, training and awareness for reception staff. So one of the things that we've heard from communities is that it's difficult to get to the receptionist or to get past the receptionist. And so we need to look at that again with a compassionate and kind approach, but actually for the receptionists as well as the people that are trying to access the services, because obviously it's quite difficult to be in those roles. We've got BSL advisors now have joined Citizens Advice. There are health fairs happening across lots of the different communities. We're looking at dental access and supporting people to access dentistry. We've got the Women's Health Hub and lots of work going on in there around providing that more continuity of care in a language and in a way that is easy for people to understand. GP practice looking at having a clinic specifically for people in sex work. We're looking at refurbishing there's 3 Gypsy Traveller sites that are ready for refurbishment. And we're doing that collectively across the patch with St Leger Homes, but also Marius and Whitley are involved in that, and the trusted people within those communities already, so that it's not just about a building, it's about what can we wrap around and how do we build trust within those communities, because that's really difficult. And then we've got just refurbished. We've just refreshed the Ethnic Minorities Health Needs Assessment Plan, which this year we've really tried to pull the action plan together for all partners, so that it's everybody's business to be looking at what we're doing around that plan. So midwifery services are reaching out to Core 20 Plus for the maternity element, for the cancer, the brief intervention training. So we got some money for timely cancer presentations, so we have directed that funding to our Core 20 Plus communities, looking at helping voluntary sector organisations to go out and talk to their communities, or to educate their communities about all-cause cancer. As I mentioned before, the SMI health checks, the target is set at 75%, but RDASH have set themselves a target of 95%. COVID and flu vaccinations, so we've got the health van going out to the more deprived communities and those that perhaps haven't got easy access to GPs to offer the vaccinations. And then we've got lots of different things going on around the blood pressure finding and the lipid. And I think you would say across all of it, we've got pockets of excellence. But what we really want is for those pockets of excellence to become really a bit more business as usual. I don't know if I'm... Sorry, do we go to the next slide?
Yeah, I'll do these.
Okay.
If you want them to.
I'll turn off.
So in the report we provided you just with a couple of examples, and didn't want to go to them in huge detail today, but did want to remind you again of the Project 6 visit that we did. And this was just a sentence that we heard back from the service as well, and feeling that they felt really seen and heard by those of you that went to visit as well. So that element of strengthening and bringing in community voice and listening to the lived experience and that co-production in developing services. Sex workers, we've got a quote there from the person that's working with sex workers, and how she's used existing trusted services and built trusted relationships to be able to encourage women who are sex workers to access sexual health services, to use needle exchange, and to access hepatitis testing as well. Around proportionate intentional resource use as well. Whit and Marius, would you like to come in with some more example or some more detail around some of the work that you've been doing that we included in the report as well? Yeah.
I don't like these things. Hi everyone. So what we started to do at the start of last year was we took the health bus to some of the Gypsy Traveller sites in Doncaster. It was asked for previously. We did do it as a trial run, and what we did is we took the bus there and a nurse, so like a health practitioner, Catherine Bebb, who's now a matron. Obviously, this is on YouTube, and we're not going to go into personal things, but from us taking the bus to the sites, we identified a number of things that people do need support with. And what we also identified was when we was speaking to people that come onto the bus, that they was telling other people about the bus. So they was then driving down for some support. So, for example, some dentistry, advice, on some certain, obviously, epilepsy, diabetic stuff. There was stuff like that, mental health. A lot of things that are identified was things that probably could have been resolved beforehand, or more information could have been given beforehand. everybody on the site was very welcoming. Like I say, people have asked for this. We liaised with the person who owns the site, a lovely woman who welcomed us on. I think when we spoke to some of the people on the site, people did have the NHS app. So again, when you mentioned earlier, Rachel, the term hard to reach, these communities aren't hard to reach. They're asking for our support, and that's what we should be delivering on, at the bare minimum. So yeah, another example was somebody wanted some support with the GP, with a referral as well. So there's a lot of quite important factors that I've just named that are in a lot of communities, but things were identified by a few visits, obviously, on the bus, what we'd like to help and support with. We did want to move to different sites. People have refused it due to the refurbishment. So what people are saying is that the basic part of living, which is absolutely true, should be at a standard where they can actually live and they can actually do that. At this point, it's not. So on the St Ledger sites, it's not. So there is rats, there is mould, there is damp, there is rubbish, there is problems. The site refurb was meant to be done just over a decade ago. So you'll probably hear a number of different years. It was actually 12. So for 12 years, and I understand obviously we've had COVID, that stopped the world, people have been promised that the sites are going to be refurbed. They've been promised that they will have new outer buildings to live. That's not been the case. There's been reports, shall I say, that they've been out, people have been out to visit the sites in order for them to design the outer buildings. Obviously, it's where these people are going to live. It needs to be personal. That wasn't done. They sent a drone. So there's so many, wires that are crossed. Armthorpe is one of the sites as well. There's so many, promises that haven't been delivered. And like I say, if we're going to improve people's health, where they're living it should be at the very least. You've got to think it's what you wake up to every day. Your environment is such a key part of your life and your mental health. So that's obviously another reason why we did put the bus on hold, because it was asked to. And with us having the bus and bringing it onto the sites, it won't just support the community's health, but I also feel it will help bridge the gap for the services. So like Mandy, when you just mentioned about, the GP staff and the receptionist, ensuring, shall I say, that they are culturally competent, but that they feel confident as well at work and every day, and people that they're talking to and the communities that they're talking to. So, and that's same with the services that are coming onto the camp, health visitors, the health bus, etc. So yeah.
I just think it's worth mentioning that we've had a few workshops linked to the site refurbishment, and that St Ledger are really on board with this now in terms of the refurbishments and doing that with a health and wellbeing focus. And the director and the chief exec, they've all been out to the sites, and they've all taken time to speak to the communities and to understand what it is that the communities are wanting. So I think it feels positive, really positive in terms of next steps for that site refurbishment. So I thought it was just worth mentioning that.
Thanks, Whit, and thanks, Mandy. And I think it was only in COVID time that we actually began to have dedicated link workers with our Gypsy Roma traveller communities, and it has taken that time to build that trust and relationship across communities to really understand what specific health needs, the really basic health needs are. So, and I know you've got a number of other examples as well, which might come out later. And then let's see, so the other one there around STOMP. So this is for people with learning disabilities, and actually working with them, involvement, saying what's important for you, and for being able to develop an approach there. And we've talked about the STOMP project in the report too. So again, Mandy, do you want to pick up these? So our last couple of slides are just about what we're doing in Doncaster, and then just a summary, and then I think we've got some questions. Go ahead.
So again, just a bit of a summary on how we're working to tackle health inequalities in Doncaster. So health inequalities are running through all of our strategies and action plans. So ICB, DBTH, RDASH, the City of Doncaster, the PCN, the voluntary sector. And actually, it's in the ether, which is really great to see. We're definitely much more pro-equity, and health and care services are becoming more disproportionate and intentional. So timely cancer presentation monies was directed at Core 20. The Women's Hub, we got some money around Women's Hub, and improving women's health has been directed at our inclusion health groups. But there is still a lot to do. So, you know, I'm not saying that it's all solved, but we definitely can feel that the direction is that we are focusing on our more vulnerable communities. Recognising that when we are connecting with our Core 20 plus communities, it's really challenging. It takes much more time, not just a bit more time, it takes a lot more time. More patience, more understanding, more compassion, more curiosity, more courage. I think it's, and I think in a world where everything is so busy, it's difficult, I think, sometimes to be able to just pause for a bit, or for organisations to necessarily take that time. But actually, I think there has been a step change in that organisations are doing that. We've talked about that already. So Thrive, we're building on the community. Doncaster's just got such a good history of community-centred approaches, which I think has been around for a long time. That integrated neighbourhood working and recognising the role of the voluntary sector and how important they are when it comes to connecting to our more vulnerable communities. I think, again, coming back to sort of that business as usual, that recognition that we have to strengthen the community voice. We must listen to what communities are saying. We've got to give time to building that trust. And that we should be co-producing solutions, and we should be doing that from the beginning of any project, not necessarily halfway through or going out at the end to say, well, we think that we want to do this, what do you think? And again, that's becoming a little bit more business as usual than it's perhaps been. Building a consistent approach to educating the workforce. So DBTH have done some great work around a health inequalities education programme, and South Yorkshire are looking at that and how we might be able to apply that to health and care, because what we want is consistency in the workforce, and their understanding of health inequalities, their understanding of poverty and the impact that that has on people's lives and their ability then to be able to access services. There's obviously the wider and commercial determinants of health, and how do we engage, you know, the thing that takes people out of poverty is employment. It's important to be living in a warm house and to feel secure. That physical environment, and those that allowed you then to be perhaps a bit more sighted on having healthy behaviours. So all of those things wrap around people and really important as part of this work. And then we're increasingly working with the Health Determinants Research Collaboration. They're going to be working with us on the Gypsy Roma Traveller Health Bus, and actually I think lots of other things. So in summary, 41% of our population are living in the most deprived, 20% nationally. Data actually is quite poor. So for many of the communities we're talking about, they don't declare their ethnicity, or they don't declare which community they're from, because that sort of they're worried about the stigma and the discrimination that might bring. Poverty drives health inequalities, which result in poor healthy life expectancy. But that's what's driving the demand for health and care. So we have to tackle health inequalities. People experiencing health inequalities do find services hard to reach. And so I think services got to try harder. We need continuity, more time, more patience, more compassion, and more understanding. Services can be immersed in the operational priorities, and you know, we've got ambulances queuing up, we've got long elective waiting lists. It's difficult sometimes to get in to see a GP. So how do we create the time and the space within operational services to be focusing more on health inequalities, and to be getting to the early intervention and prevention, so that we're stopping people getting ill in the first place. And decisions can sometimes be made unintentionally to increase which do increase the inequality gap. So if you look at something like digital solutions, so many of our services through COVID became virtual, and actually for people who don't have a phone or who haven't got access to those sorts of things, then potentially that makes it harder for them to access. So I guess, how can we all become much more intentional and disproportionate in allocating resources where they are needed most? And how do we make sure that all decision making is through an equity lens?
Okay, so I'd like to say thank you for that. That was really informative and clear, as was the report, to be truthful. But we have got some questions. It wouldn't be scrutiny without questions. So we're going to start with a question from Martin.
Yes. Is there a national or local target set for annual health checks in severe mental illness? And is there additional payment to the GP practices for this health check?
We can give some more info around that. I think we just put it up on the slide as well about the stretch target that Ardash have got, but I'll bring Elsa to come in just a moment, but wanted to give some broader context around health checks as well. So we've got 3 different health checks functions. We've got the NHS health checks, which is a check for cardiovascular risk, checks your blood pressure, and that's for people aged between 40 to 70, and that's offered every 3 years. Our NHS health check service is commissioned by Public Health and available across Doncaster, so if anyone's interested, please do promote that in communities. And then there's 2 focused health checks as well. So health checks for people with a serious mental illness, and that's for people with bipolar affective disorder, for psychosis or for schizophrenia, and that's offered every year. And again, that's a cardiovascular and an overall health check as well. And then there's also health checks for people with learning disabilities, and that's an annual health check when you turn 14 for the rest of your life. That is a broader offer of a physical health check, and that's delivered through GPs. So just wanted to, as we were answering that question about health checks for people with serious mental illness, just describe those 3 types of health checks. I know we said in the presentation about that stretch target of 95% in Doncaster, but Elsa, I wonder if I can just bring you in around some of the mechanisms for it as well.
Okay, thank you. So in terms of your question about is there a national target, yes there is, and that's 60%. And as at September 24, get the right year, for Doncaster it was sitting at 68%, so it was above the national target, and it's sitting at the highest in South Yorkshire. In terms of how that's provided, you asked a question about QOF payments for GPs. There is a QOF payment, so there's a mechanism to pay GPs, but we've also contracted with Ardash in terms of delivery of the service, and that particular focus of the Ardash service is around that approach to health inequalities. So how can we do things differently? It includes aspects such as peer support for people when they're going to their appointments. It means that the appointments can be offered in different places, in different ways. It can be part of seeing a clinician that they're used to seeing on a regular basis. So we've found that different offer is something that's working really well for that cohort, which is why we're sticking with having Ardash supporting what we've got as well. So people have got 2 different ways that they can start to think about how to access to get that health check. But it's made a real difference. So at the moment, for us, it's getting us in the right direction. In terms of that local ambition, it's one that Ardash have set themselves. They've got a set of promises that they're working to as an organisation, and it's one of those promises that they want to work towards to say, actually, we need to get an even greater proportion of that particular cohort of our population being able to access that annual health check, because we know how important it is for people to be able to access it. Is that okay?
Yutundi, I think you're next.
Thank you, Chair. So my question is, in the Gypsy Roman traveller community, where the health bus was allowed, has there been any agreed frequency of visits or operations? Do we know about referral? I know you've talked about referral in your presentation to the public health services as a way of bringing the community in contact with other health facilities. And before you answer that question, please, because during the course of your presentation, I picked up something else that I think I could add to this. Do we know if there is a plan to bring maybe a same-day service center or GP, into GP services into the Gypsy community? Thank you.
So again, I'll bring Marius and Whitton with some of the detail around that as well. So you've asked about the health bus and its operations. I think Whit's just described as well about that kind of step-by-step process. So first it's almost like the exposure of here is a health bus and here's what it offers, and then one or two people from the community taking that trusting step to see if it's right for them, to see what's there to offer. And the health bus service itself has very much been formed around what people have said that they've wanted. So I think you saw in the report as well, we're then able to offer support around children's health. I think what Whit described earlier was that call or that response from the community are actually, it's fine to bring the health bus, but the sites that we're living on are not helping us to live our healthiest lives. So there's something more fundamental that we need before we can keep going with that trust piece of how we access our health services. But I'll just, Marius, I can see your finger hovering over the button, so I'll let you come in as well for Councillor Tunde.
Thank you, Councillor Yotunde, for your question. And I think that somehow the situation should be seen from the lens of health inclusion and health inequality, closing the gap in a multi-level or intersectional manner. So, first of all, the bus in itself is not just a purpose, but it's a tool how to narrow the communication gap. Some people might call it cultural. I don't like it, but this communication gap that exists historically between the public service and Gypsy, Roma and travelers community. Just to give you a sense that it was promised by the public authority that the 3 sites that we are working now would be refurbished for 12 years. So they are in a public debate, and the political promise was there. So this type of relationship somehow cannot be solved overnight, but there is a need for time and for doing step by step. If it's needed in a public policy, the so-called salami slicing approach rather than putting the things around. In terms of referrals and how the Gypsy, Roma and traveler communities are accessing the health services in general, I must say that it's difficult and there is a structural barrier on collecting accurate data at the local level. For instance, even now in a drop-down menu, you cannot record ethnicity of Gypsy, Roma and traveler in many health providers. But through our database and through our data collection, we can say, for instance, that in GP registration since 2022, and it was last month, Monday, we seen more than double the registration, regardless of the fact that we have some structural barriers or so-called, as it was mentioned by Mandy, the fear of being labeled, the fear of exposing their ethnicity into that. A simple example it is that, for instance, the Flying Scotsman GP practice, it's known, and we have the anecdotal evidence is that it's the GP of immigrants and majority of Roma from Hextorp. They are attending on a regular basis there, but this is not reflected in their official records, just to give you an example. However, we sense, as I said, double number in declaring their ethnicity, at least at the level of GP practices. It might be in other facilities as well. For instance, we worked last summer, DBTH, they reorganized their interpretation and translation services, and we work closely to make sure that Romani language or Gypsy language would be introduced there, as well some providing them some know-how and information from the community how to make this service available, but also more appropriated to answer the specific needs of the community. Thank you.
Thank you very much. Yeah.
Okay. The next question's mine. So I really don't want to create an impression that, you know, I think Stomp is of any less value or anything like that, because I understand that. But is this the area where most premature deaths are happening in learning disabilities? And I understand very much, to my huge disappointment, and I can't tell you how disappointed I am, that the national target from government for 2025 is no more, which I find personally extremely disappointing. So, will this have a detrimental effect on the health of our learning disability population in Doncaster? Do we still pay that additional QOF payment to the GP practices for the learning disability annual health checks? And as an ICB, is there something in place to kind of replace a national target? Because I'm hearing personally from the learning disability community. Only this morning, a gentleman called Scott Watkins, who I've known for many, many years, who works for Seeability, has put something on social media around people with learning disabilities, you know, are being forgotten because there is no more national target for the annual health checks. So I just wanted some reassurance, really, around why Stomp and what are we doing in Doncaster around the percentages for annual health checks.
So I think Ailsa can answer around the health checks themselves. On the why Stomp, we want, in the examples, case studies that we provided you in the report, we wanted to illustrate some of those important approaches of working with people in inclusion health groups. And we thought that the Stomp project was a good example of that understanding and compassion and involvement. So it was saying to a community of people with learning disabilities, what's important to you? They'd looked at the evidence and what had worked in other areas, and that was chosen. So we used it to demonstrate involvement in and compassionate approaches rather than, I guess, kind of ranking what's most important for life expectancy. But Ailsa, if I just bring you in around the health checks.
Thank you. Probably just a bit of context then in terms of the national target and the way that we would tend to work, and then I will come to Doncaster specifically. So absolutely appreciate we've seen a change in terms of what's come out in the planning guidance this year. So every year we get a set of planning guidance that say these are the things we particularly want you to be looking at. These are targets that are set nationally. And the planning guidance that we've had this year overall is quite light. It's quite high level. It's a lot shorter than we've seen before. But I think the important bit for me is if something isn't listed in there in terms of saying, okay, here's your target, we don't take it to mean that that means that the target goes away or it's not important. So a good example of that is, for a while, if we think about, it's very different, but 18 weeks referral to treatment target. For a long time, there was a focus on 18 weeks. We've then had a couple of years where actually the targets have all been around how many people actually have had the longest wait, so how many people are waiting over 65 weeks. The 65-week bit is dropping out and we're coming back to thinking about 18 weeks. So we do see that national shift in exactly what targets are set out in planning guidance. But if it's not in planning guidance, does not mean that it's not a target and it goes away. So that's where I think it sits from a national perspective. There is still the element, it will be in GP QOF, so it'll still continue to be there, which means that the data has to be collected and it will be reported on. So that doesn't take it away, which is good. Most importantly, I think for Doncaster in South Yorkshire, we're absolutely sighted on it, and it's not something that we expect. It won't be going away as a target. It's something that we look at, we measure, And we know it's really important. There's been lots of work done to say how important it is that we can offer that health check for our LD population, and we've got no intention of that getting any less. So from our perspective, in effect, it's no change in that nothing goes backwards. I'd like to see it continue to increase the same way that we're talking about our health checks for our SMI population as well. But it should absolutely not drop off the certainly our local list of what our priorities are. So I hope that helps a bit, and I'm more than happy that we keep reviewing this during the year to make sure that nothing is dropping off. I'm comfortable it won't, and I know there's a conversation at South Yorkshire level as well. There's a conversation early next week just in terms of how we make sure that we get that signed up to. So I don't think it will be going backwards, but really happy to be held to account for that as well, because it is important and we have to do it.
Can I just ask then, what we said was, I'm sure that Ardash have a contract around SMI health checks. Where does the contract sit for learning disability?
For learning disabilities, it's still with GPs. So the provision is primarily for them to provide. So far, in terms of getting to that 75% target, we got there last year in terms of reaching the target. Having a look at where we were at in November this year, it's calculated a bit differently, this one. It's a cumulative target, so you won't hit the 75% till you get to the end of the year. But in terms of where the amount that we're done in November that's just passed in 24 compared to the year before, it was ahead. So we've done more in November 24 than we'd done in November 23. So that leads us to think there's no reason, again, why we shouldn't meet the target at the end of the year. But this is delivered through GP practices particularly, rather than with the Ardash support.
I think Laura's got the next question.
Thank you. As a scrutiny panel, when the easy-to-understand information is discussed as part of the project, it would be really helpful for us as a panel if we could see that information in order to see the benefits, or if you're using alternative methods of communication like short videos, sounds, things like that to explain. It'd be really great if we could see them. Is that something that's possible?
Yeah, I think Mandy, you've been in touch with the lady that works on this project, so it would just be a process of working out the arrangements.
Yeah. So she sent me a whole load of different things that are available, and so I can just forward it on to everybody if that's helpful. There's a lot of it.
Okay. Is that all right, Laura? Yeah. This is a personal plea, in a way, the next question. As the chair of this meeting, I am the lucky person who goes to the South Yorkshire Scrutiny panel. And I'm sure Caroline will bear this, will support me in this, is that one of our near neighbours never miss an opportunity to say at that panel, Barnsley, I'm going to dob them in, how wonderful their access to healthcare is in their centre. And I would very much like to be able to say that we have some similar places where people from Doncaster can access. I realise, and I personally know the success of the health bus, which currently is in my ward regularly, but they have, a permanent place in the town centre that they never stop telling the rest of South Yorkshire about. So I would dearly love to be able to say that Doncaster has a similar facility.
Yeah, so I'll bring, so I think you're talking about health on the high street, it sounds like it. So we do have health on the high street. We've got pharmacies, and I'll give a plug for the pharmaceutical needs assessment that's gone out. So we do have pharmacy provision. Will we have something for Doncaster? Probably yes, and I'll bring Elsa in a moment, but it's absolutely crucial that it's the right thing for Doncaster residents. It's in the right place, it's open at the right times, it's doing the right things. There's thought about actually what does it do, where would the staffing provision be, and how is it really kind of moving that preventative shift as well, so it's not just a relocation of a service. But Elsa, if I could just bring you in really briefly on where we are and what next.
Thank you. So bottom line is, yes, it's part of the plans that we've got in Doncaster in terms of something that we would like to do. It's part of a set of priorities that all our chief executives across health and social care have been developing for Doncaster to particularly say, so what's the longer term vision for Doncaster, not just think sort of 1 year at a time. So one of those ambitions is absolutely doing something around health on the high street. As Rachel said, it's really important that we get it right for what's right for Doncaster. But we've started the work in terms of both what that could be, what it could include, but how, as Rachel said, that we transform those services, so we're not just doing a lift and shift either. It's about getting it right and doing things differently. So we started that journey, but also the journey in terms of so what might that look like in terms of where in Doncaster and how. So if you can hold with this, there should be some comms coming out in March that will start to say a lot more in terms of what it looks like for Doncaster, but it's absolutely forming part of what we think is part of that kind of 5-year vision in terms of how do we shift stuff around and get the health provision into the places that we think it will make the most difference.
And wouldn't it be wonderful if, as a Health and Adults Care Review and Scrutiny Committee that have had insight into the JSNA, have heard and listened to us today around health inequalities and inclusion health groups, that you perhaps in the future welcome an item around health on the high street, applying some of that scrutiny to, has that work been done to prepare and to really focus to be that over-focused and disproportionate for health inclusion groups?
Thank you for that. So our next question is from Sue Knowles.
This is a request for information, really. It's paragraph 21 on page 24. It's about NHSE funding allocated for timely cancer presentation and for the development of women's health hubs in Doncaster has been directed to core 20 plus groups. A customer-centred approach led by the VCFS to develop culturally appropriate videos, desensitisation kits and etc. And it's the desensitisation kits. I don't know what that is. If you could explain it, please.
Oh, Mandy's raring to go. I'll have a go, Mandy. You could add something in.
Oh. You go.
Yep. So desensitisation kits and desensitisation approaches are commonly used in inclusion health groups. So if you think about a person with a learning disability, if we're asking them to go along for a screening for something or a health check for something, actually they might have a really difficult attachment to that healthcare environment. They might have had a poor experience, something they've not quite understood, and going into that can promote that fear. You don't want to be measuring someone's blood pressure when they're already feeling worried or concerned. Also things like actually if somebody needs to have a vaccination, then what's that desensitisation process of getting them prepared and ready for an actual jab. So it can include things like talking people through and information, but it could also include just touching somebody's skin or walking them through a clinically simulated type environment. For the cancer type approaches, again, if you think about people from different backgrounds, and some of our cancer screening can be quite invasive. If you think about our bowel cancer screening, it's a wee card that comes in the post and you to put a bit of your poop on it and send it off. That might be more acceptable to some people or some communities than it is to others. Cervical screening, imagine if that's the first time you've been before, if you're somebody with a learning disability, or actually if you're somebody from a different culture that isn't used to removing items of your clothing around somebody that's not a close member of your household, and breast screening itself as well. So we're asking people when they're being screened for cancer to do things that they might not be entirely comfortable for. So actually a desensitisation kit is a way that we can demonstrate to people. So say if you've got a group of women that have never been for breast cancer screening before, you've got a kit, so you've got a fake boob and you've got some other things that you can say, this is what to expect and this is what the pressure would be like. Or again, if you can talk them through what an experience of a cancer screening would be like, so that when they're there, they feel ready and prepared and they're able to answer all of those those questions about what might happen to them, be able to ask for a buddy or an advocate to go along with them. So it's just not just expecting it will say, here's your invitation for your screening and the person will turn up, because we're widening inequalities with that. You'll get your people that just don't feel comfortable with that, not able to read. You're missing the opportunity for them to be screened, but we need to be extra compassionate, take the extra time, take some more understanding. Mandy, have I covered the DSA?
That was amazing.
So, has that answered that for you?
Well done. So I suppose it's the kit bit that threw me. So it's not really a kit, is it? It's more of a process.
Yeah, so it can be a kit. I think if it's a vaccination, it can be a spike that you would touch on somebody's skin. It could be a piece of the equipment, so they show it like that. Have you got any more information
Well,
about
I think that,
yeah.
as you say, it's always a conversation starter. So if you can have a breast or a testicle or something, and that will have a lump on it, or so it just helps people to, one, be able to feel what that looks like, or what it feels like, and then they're able to do that on their own bodies and their own in their own homes and things. So it is it comes in a bit of a box. There is a kit, but we've had really positive feedback from people that when they've, and so we're almost being asked for more kits. So we share it around because we're good friends. But, yeah.
We could have bought.
Yeah, that would have been good. Thank you.
Next questions, Utunde.
Thank you, Chair. So I have a few. The first one is around the inclusion of people with substance abuse issue. So the question is, what's the plan of the health inclusion program in engaging people with substance abuse that are not currently seeking help? For instance, maybe they've not identified that they've got issue. So they're not attending Aspire. Is there a possibility of working with establishments in the communities, gatekeepers, so to say, people who have access to these people? For instance, pub landlords, community places where we can have QR code posters where people can seek for help. You know, this is just to support people who don't want to be stigmatized with them identifying with the issue that they are going through, which will kind of like balance the health inequality, so to say, if you understand what I'm trying to say. Is my question clear?
Yes.
Thank you.
Well, I'll give an answer and then you tell me if I've understood it well enough. So you're asking about people with substance use issues, or people that misuse alcohol. So when we had the visit over to Sober Social and when we had the presentation from R-Aspire services and from Zone 5 to 19, I think in that they demonstrated how they'd moved and changed in the last year and how they'd reconfigured their service. So we heard about the OAT team, the outreach team, which has launched. If you follow any of the R- or Aspire comms, they've been really promoting their service. They did a brilliant video, which was a person demonstrating how they actually physically get into the building and how positive and warm that welcome is once you access the service. We heard about the coffee cart as well, that the Sober Social people are going around with, so going around and actually talking to or engaging people in services. We've got women-friendly sessions now as well, so they have craft-focused sessions that allow women to build those bonds, women that are either in recovery or considering recovery, to build those bonds and build. We talked about how important social networks are earlier. And then Zone 5 to 19 service very much works with the schools as well and younger people with substance use issues or at risk of substance use issues. The services themselves are where the expertise and the skills and all of the resources sit, so that's the right place for them to be. I think we do use, or we have used, posters to advertise services. We've also got things like the scratch cards that we use, where people can evaluate their own alcohol use. We've had various campaigns, Rethink Your Drink, in January as well. So a number of ways that we advertise the service, focused advertisement to different groups, so it to try and remove that stigma. And that was the whole purpose of our session at the end of last year as well, for us to demonstrate and understand that a substance misuse service is welcoming of anybody and everybody that needs it. And hopefully if you've not had a chance to yet, we can send some of the links to the Aspire Facebook page particularly, and you can see how they've been advertising the new elements of their service in the last few months. Has that answered that, Councillor Utundu?
Thank you, Rachel. It does to a certain extent, but my question is around a subtle approach. So say, for instance, when you visit some public toilets, inside the cubicle, you see posters, QR code about seeking for help if you are vulnerable, you're going through abuse and things like that. I'm just thinking of a way of that where people will not want to be identified with a group. They don't want to attend a session. They're struggling. They don't want anybody to see them struggle. But when they're alone and there's actually nothing in your face that is actually spelling it out that this is the big problem, I think it's easier for people at that moment to be able to seek help, because it's not in your face, but at the same time, you're able to get those information. That's the kind of support I'm trying to talk about. Thank you. Can I go on? All right. Okay, so the second question is the inclusion of healthcare workers. And before I ask the question, I want to give you a little bit of background information. I used to work for the NHS. I did that for 13 years. And I started working for NHS in 2003. So I saw the way things derail from that period till the time my service ended there. And I've witnessed a situation whereby it was extremely difficult to get time out to attend appointments, healthcare appointments, because of the rule. I don't know what the rule says now, but when I was there, the rule is that appointments that will be free would have to be 1 hour or less. If it's more than 1 hour or less, you need to book an annual leave to get an appointment. We all know how difficult it is to get an appointment. And it's also extremely difficult to get annual leave if you are working within the NHS, because you need to give so much time in advance to get that time off. So I've seen people, including myself, sacrificing their annual leave and having to postpone and lose out of appointment, which, in case if it's a serious ailment, say like cancer now, it's a matter of time. So it's not something that you can delay to say, I can't get an appointment now, and then in 3 months' time, I'll get another appointment. You have that very little window period for you to get on it and get treated. You know what I mean? So I've seen a situation also whereby healthcare workers, such as doctors, having mental health illness, not having proper diagnosis, time to look after themselves. How do we look after people like this? Has there been consideration in including healthcare workers, doctors, nurses, etc., suffering from mental health issue, staff working long hours, not being able to make appointments? How do you plan to catch these people in these health inequality issues? Thank you.
Okay, so like we've got Mandy as our health inequalities nomad, we've also got Fiona, who's our NHS and workforce nomad. So we will, if we're not able to answer some of what we've collected from Fiona today, we'll come back with some more detail as well. But as you've said there, the health and care workforce themselves not described as a health inequality or inclusion group, but I would absolutely expect that all of the aspects of inequalities and inclusion health that we've talked about today to apply through such a vast workforce. And I would expect that that the various HR practices that exist in different NHS organisations in cross Doncaster should be operating in the way that allow people who work in those fields to prioritise their health and well-being. But Mandy, am I okay just to bring you in on some examples of some of the other broader workforce well-being stuff?
Yeah, and I think we can absolutely raise this for Fiona to take to the Chief People officer meeting. But she has sent me some information again, which I'm happy to share with you. But it talks about, I suppose, she's been focusing on what's the health and wellbeing offer for health and care staff. So things like they've got 24/7 access to a mental health hub provided by VivUp. There's a lot of support around finance. There's lots of opportunities to access counselling. There's quite a big programme of support around menopause and things for women. When it comes to things like the, well, certainly cervical screening, I know DBTH staff can access cervical screening on site, so they don't necessarily have to go away from work. So I think there's lots of services around. There's lots of opportunity for staff to be able to access them. I think the question that you're asking probably does link more to the policies in terms of special leave and how people manage that. So I guess that feels like that's maybe the question for Fiona to take away from this meeting, just to take to. I don't know if you've got anything else, Elsa.
I've got nothing specific in terms of thinking about how each organisation make sure that their staff can attend appointments appropriately. The only bit I thought it might be helpful to share is thinking particularly that GP access bit that I know can be really difficult in terms of the Doncaster Same Day Health Centre. That is available for people that aren't registered with the Doncaster GP, and part of the thinking behind that is so that if you have got people working in the Doncaster area, then they can use that facility. I appreciate we need to go back and check in terms of so how would they be able to take the time out of their work to do that, but at least they have a local opportunity that they've got rather than trying to think and then they need to get back to wherever they come from to see a GP. So we've done that deliberately to try and ease that, but I think clearly that is a good question that I think we can take back to find out a little bit more about. I mean, I know what the ICB's approach is, but thinking about clinical staff particularly, it would be helpful to come back to that.
Yeah, thank you very much. I'm glad that you actually got the main aspect of my question, which is it's not living and breathing something, being situated or surrounded with all these facilities and resources is the ability to actually get access to the ability to be able to access and use them. The 13 years I worked with the NHS, only 3.5 of it was spent in Doncaster. I live in Doncaster and work elsewhere, and I know a lot of people that did around the same time. So I used to work in Leeds, I used to work in Barnsley, and I'm still living in Doncaster. All my life is in Doncaster, but I'm working elsewhere. I know a lot of people who does that. So it's difficult to get that time, because by the time you make the appointment and then you're going back to work, it's not worth it. The whole day is already gone. So it's looking into things like that, especially for people who are looking after the health of others. Thank you. All right, my last question is around elderly people situated in care homes. So the question goes thus: has the health inclusion team considered how to include elderly people in reducing health inequality, especially those living in care home? Could you explain what more could be done to support this within the community? Thank you.
Again, do tell me if this answers either some or all of your question. And I have put an ask out to some colleagues at RDASH as well, just in case there's any further information that you need or you have. So my first thought from your question is around care homes, residential homes, extra care homes themselves as a possible or a potential asset within communities as well. So we've, when you look at residential care, what can those places, particularly the extra care homes as well, how can they be better as a part of the community as well? How could they have the wider community go in and use them? Many of them have cafes and other aspects as well, community rooms. So I think there's some opportunity there about bringing in people that just happen to live in residential care homes into part of that broader community. My other thought as well was about around the planning for future residents of care homes as well, and this has been picked up by the ethnic minority health needs assessment and through the action planning as well, that as we've got a more diverse and different population in Doncaster, what might residential or care home needs be in the future, either cultural or other as well. So that's part of the Health Needs Assessment and Action Plan. Again, people who live in care homes aren't described currently as a specific health inclusion group, but would expect, again, them and increasingly to represent a variable community. Health and wellbeing things, so I probably know most about mouth care. We've just completed a dental survey of people who live in care homes to assess dental oral health, and would expect there to be, again, a variation in health status of people's oral health. I have asked a specific question to a team in Ardash about health and wellbeing, either services, aspects or support for people resident in care homes. And when I receive some more information back from them, I might be able to give you a fuller answer. But just checking, so your question itself was about either how we consider the population of people in care homes or how we consider the health and care provision or the health improvement provision of people in care homes?
Sorry, no, that's not my question. My question is around, because I used to work in care home as well. I'm sorry if it looks like I'm taking experiences from where I used to work, but that's a long time ago, like over 20 years ago. And I realized that whenever residents are to go to hospitals, you know, sometimes they get this referral or you have a case of accident and emergency, an ambulance had to come in and all. So they usually come back worse than they were. And a lot of them used to be very scared of going to hospitals. And you wouldn't blame them because of the long waits, long hours of wait, them being uncertain about their environment. You know, they've been used to a certain place, then they are now in a new place. So, which I think is a kind of inequality as well because of the situation they found themselves. So that's why I want to focus on that. Is there a process of managing their healthcare support when they leave that vicinity and then they come into the main public health services?
Okay, I think I understand better. I'm doing an eyeball at Elsa because of the link to urgent emergency care as well. So, Elsa, are you okay with that?
Yeah, I think there are a few things that I can mention. So, as part of our care homes and the support to them from a primary care perspective, there is now an expectation that all care homes have a link with one of the primary care networks that we've got across the patch, and the primary care networks have a responsibility. It's called Enhanced Health in Care Homes. So there's an expectation that there's a multidisciplinary team that will have a weekly catch-up with that care home. It's usually weekly, it'll vary a little bit, where they'll discuss any residents that they've got, where they've got ongoing issues, if they've got concerns about it. So there's now a regular contact with the care homes to say, what does that look like in terms of ongoing care? In terms of then support for people, in terms of going into hospital and out of hospital, we will have people that go in and out depending on their healthcare needs, but a lot of support's been put into our care homes to support them around that decision making in terms of if they need an ambulance, if they need somebody to come out and they need hospital or not. So we've been working with them to make sure they've all got access to a thing called the I Stumble app. So that's an app that they can use if somebody's fallen over to determine whether they actually need more support or not, or if they're safe to stay where they are. So that's been really effective in terms of reducing some of those conveyances to hospital. So we've got that as a real sort of physical app, but we're doing a lot of work with care homes in terms of their confidence about when to call an ambulance and when not to. And we've seen some really good success in some care homes where they were conveying quite a lot of their residents to hospital. We've seen a real drop-off through that focused work to try and make sure that they're aware of all the support there is, but get that confidence up as well in terms of trying to change what that looks like. I think the final bit is we do have services that can go in and respond. So particularly if you've got a residential care home, then either our emergency care practitioners can go in who can do an immediate assessment, again, of what's happened to somebody and if they think they need onward care. We also have our urgent community response team who can provide that longer input over 2-3 days. So if somebody needs something but it can't be resolved there and then, but they need a bit more monitoring and following up, then the urgent community response team can also do that as well. And again, we've been working with our care homes to make sure that they're aware that they have those resources that they can tap into. So they don't just sit and think, I've got an unwell resident, I'm worried, I'll ring 999. So the provision is looking very different from what it was, but there is still, as ever, there's still more work to do. We know that the staff in care homes can often change, so it's about making sure that all staff are up to date in terms of the support that there is. But we have regular forums now with all care homes as well, from our perspective, to be able to get out and talk to them about what's there to help them. So hopefully that helps a little bit as well.
Yes, it does. Thank you.
Right. So this report is for information and discussion. Sorry, does anybody else have any more questions before I sum up? So this report is for information and discussion for Health and Adult Social Care Scrutiny Panel members. And we're asked to note the examples of work happening across Doncaster to tackle health inequalities, with a particular focus on inclusion health groups. And the paper will also highlight the importance of applying an equity lens in all that we do. I just wanted to say, really, before we kind of leave, that just a couple of things have really heartened me this morning. One's the improvements that are happening but are very much ongoing in the GRT community, and that's clearly very positive. And the other thing, there are just two words I wanted to take from Project 6 that made my heart sing, really, and that was seen and heard. And I think the fact that we were out there listening to people who use those services, who were so honest and told us how they got there, what they were doing, what the future plans were when it had all gone wrong. We met such honesty that morning, and people happy to tell us where they'd been and where they were now. That was, I think, for all of us, a really positive experience. So I just wanted to say that, really, because seen and heard really came home, and I think is very important. I'm going to let you guys, if you don't mind, go now, because we're going to work through our work plan. And, I think after all the questions that you've had, you're probably ready for a coffee or a bit of a break before you carry on with the rest of your day. So thank you.
Thank you.
Thank you for having us, and thank you for the questions. Take care.
Okay, work plan next. So this time of the year, we've just got one more meeting in March. And at present, we've got down on that the discussion around the Doncaster Dementia Strategy. Is it 23 to 25? So work's just undergoing at the minute to look at what that meeting will look like. And so that'll be coming up on the 20th of March. There's no more meetings after that. The only other ones are OSMC Finance and Performance Q3 meeting, and as usual, if you've got anything, questions you want to raise in any targets or anything in the report, you can always channel them through the chair, who can ask them at that meeting, particularly on health areas and adult social care. So looking at the forward plan, I can't see anything on there that is specifically for this panel at this time. So apart from the quarter reports and about a grant for Doncaster about drug and alcohol, but that won't be for the consideration by this panel. So that's all from me, Chair. And if you want to add anything, I can close the meeting.
No, I don't think I've got anything to add. I think we've got some work to do around the next meeting, and I'd really just like to thank everybody for the support this morning, and that ends our meeting. Thank you.